Welcome back for another deep dive. Today we're really laser focused on something fundamental, I think, for all veterinary clinicians, understanding and, well, tackling acid-based disturbances.
Absolutely. We know your time is valuable and you need the crucial stuff fast.
Exactly. So we've taken a pretty dense technical document on acidosis in small animals and distilled it down.
Yeah, the goal here is really a clear, concise, and hopefully immediately useful overview of this whole topic.
Our mission then for this deep dive is pretty simple. Give you, the busy clinician, a practical rundown. What causes acidosis? What's happening physiologically? How does it, actually look in your patients?
And the key diagnostic steps, treatment strategies,
Mm-hmm.
basically hitting the highlights from etiology to prognosis, all geared towards helping you make those quick, informed decisions.
Okay, let's jump right in then.
Let's start super basic. Acidosis. Fundamentally, it's a net increase in hydrogen ions, right? And that leads to a lower blood pH.
Simple enough definition.
But the absolute crucial thing, always, is that acidosis itself isn't the primary disease. It's a flag, a sign something else is off.
Right, like that check engine light. It tells you there is a problem, but not what the problem is. So what are the main ways this hydrogen ion buildup happens in practice?
Okay, the document lays out three main pathways for metabolic acidosis, which, let's face it, is the most common type we wrestle with. First, increased acid production.
Okay.
Think about lactate and shock, or
Well, yeah.
sepsis, or ketones and DKA,
Yeah.
big ones,
Classic critical pair scenarios.
and toxins too, ethylene glycol, salicylate. These situations just flood the system with acid. So, key takeaway,
Mhm.
critically ill patient, poison patient,
Yeah.
increased acid production, high likelihood.
Got it. Overproduction and overload situations. What's pathway number 2?
Second is failure of acid excretion.
Yeah.
Mostly, we're talking kidneys here. They're supposed to get rid of these fixed acids.
Right.
So acute kidney injury, chronic kidney disease,
Mhm.
their ability to filter just tanks and get a buildup.
Okay.
Uremic acidosis. Even just poor perfusion to the kidneys without direct damage can mess up excretion too. So metabolic acidosis plus kidney issues. Excretion failure jumps up the list.
Makes sense. The waste disposal system is jammed. Number 3.
Third is bicarbonate loss. Bicarb's your buffer,
Yeah.
right? Your internal antacid.
Yeah.
You lose too much of it, the balance tips. Most common cause, severe diarrhea, just pouring out bicarb-rich
Gambling.
fluid.
Yeah, we see that.
Certain kidney problems, like renal tubular acidosis, can also cause bicarb wasting. So again, that persistent nasty diarrhea. Think bicarb loss.
Losing the buffer. Okay. Now, the document talks anion gap. Super useful, but sometimes feels abstract. How can we make that practical?
Totally. The anion gap, the calculation, A plus K plus K plus HCl3.
Yeah.
Think of it as measuring the unmeasured negative stuff floating around.
Right.
A normal gap, roughly 12 to 24 in dogs. An increased anion gap basically yells, hey, something new and acidic showed up.
Okay, so what's usually yelling?
Lactate, ketones, ethylene glycol metabolites. Those are the big three you'll see driving a high anion gap metabolic acidosis. So you see that high gap, those are your prime suspects immediately.
High gap extra acid culprit present. What if the gap is normal, though?
Good question. A normal anion gap metabolic acidosis usually points to bicarbonate loss. The body tries to stay electrically neutral, so it often hangs on to more chloride instead.
Ah, the chloride connection?
Yeah, leading to increased corrected chloride. Remember that formula? Patient chloride times. Normal sodium, patient sodium.
Right, got to adjust for the sodium.
So metabolic acidosis, normal gap, but that corrected chloride is high. Bicarb loss, probably GI or renal, is your likely culprit.
That's a useful pattern. Now, the document mentions a low anion gap. That seems weird.
It does feel counterintuitive. The main reason, low albumin, albumin's a negatively charged protein, contributes to the normal gap.
And sick animals often have low albumin.
Exactly. Very common in critical patients. And here's the clinical pearl. Low albumin can mask a high anion gap acidosis. The gap looks normal or low because the albumin isn't there contributing its usual negative charge.
Oh, wow. Okay.
So really sick patient, low albumin, normal gap. Don't automatically rule out things like lactate or ketones. The low albumin might be hiding it.
Good point. Always factor in the albumin. Okay, we've hit metabolic acidosis hard. What about respiratory acidosis? Where does that fit?
Respiratory acidosis is simpler in a way. It's all about CO2 retention. Your patient isn't breathing effectively enough to blow off carbon dioxide.
So hypoventilation.
Exactly. Slow breaths, shallow breaths, think severe pneumonia, pleural effusion squishing the lungs, maybe neuromuscular weakness affecting the breathing muscles. CO2 builds up, pH drops. Any patient struggling to breathe is at risk.
And the body tries to compensate here too, right? Like it does for
Oh,
metabolic.
yeah. With metabolic acidosis, the lungs try to blow off CO2, that hyperventilation we see. With chronic respiratory acidosis, the kidneys eventually kick in. They start retaining more bicarbonate and dumping chloride to help buffer that high CO2.
So you might see low chloride in a chronic respiratory case.
You might. It shows how the kidneys are trying to adapt to a long-term lung problem.
It really highlights how interconnected it all is. And
Yeah.
like you hinted, it's not always just one or the other, is it? We can get messy combinations.
Oh, definitely. Mixed acid-base disorders are common, especially in really sick animals. You might have both metabolic and respiratory things contributing to the pH chaos. Recognizing those is, well, it's crucial.
Okay, so who should we be most worried about? Which patients are really high risk for developing acidosis?
Well, the document says any animal can, but yeah, there are definite risk factors. For metabolics, we've hit the big ones: ethylene glycol, DKA, kidney failure, shock causing lactic acidosis,
Yeah, the usual suspects.
plus severe vomiting or diarrhea, losing electrolytes and bicarb. Even aggressive 0.9% saline infusion can sometimes cause a hyperchloremic metabolic acidosis. Oh, and don't forget Addison's disease.
Right, hypogonadotrophism. That's a good list for metabolics. What about things setting them up for respiratory acidosis?
Anything blocking or impairing breathing. Upper airway obstruction, bad pneumonia or asthma, fluid or air in the chest cavity.
Pleural effusion, pneumothorax.
Yep. And things that depress the drive to breathe, like certain drugs or brain issues.
Okay, let's talk presentation. The document says signs can be vague. That makes it tough. What clues, subtle or not, should we look for?
You're right. They often overlap with just being generally unwell. Lethargy, weakness, maybe mental dullness with metabolic acidosis. The classic compensatory sign is that hyperventilation, deep, fast breaths trying to blow off CO2.
But not always obvious, especially in cats.
Exactly. Cats are notoriously bad at showing that robust respiratory compensation for metabolic acidosis. And critically, don't be fooled if the PACO2 or bicarb looks normal on its own. If the pH is off, or if that expected compensation isn't happening, you still need to suspect acidosis.
That expected compensation. Can you remind us of that rule of thumb?
Yeah, it's a helpful guideline. For metabolic acidosis, for every 1 MEQL drop in bicarbonate, you expect roughly a 0.7 millimeter Hg drop in PACO2 from the lungs compensating.
Okay.
If your patient's PACO2 isn't dropping, like that formula predicts, that's a big red flag for a mixed disorder.
Yeah.
Something else is going on with ventilation.
That's a really practical check. Okay, so we suspect acidosis. What's the diagnostic pathway look like?
Number one rule stressed in the document: acidosis is never the final answer. You have to find the underlying cause.
Right. Treat the cause.
So thorough history, good physical exam, initial database, CBC, Chem, UA. But the absolute cornerstone is blood gas analysis.
Blood gas, arterial or venous. What's the practical reality?
Arterial is a gold standard. Gives you everything: pH, PACO2, bicarb, oxygenation. Crucial if you suspect a respiratory problem.
But arterial sticks can be tricky.
They can be. So a venous sample is often a good starting point. It gives you reliable pH and bicarb. The initial chem panel might give clues too. Low bicarb suggests metabolic low pH, with high PACO2 points towards respiratory. But remember, mixed disorders can muddy those waters.
And how do the other blood results, like electrolytes and protein, help piece this together?
Well, electrolytes can hint at causes, like we talked about with chloride. And total protein, specifically albumin, is vital for interpreting that anion gap. Low albumin can hide a high gap, remember?
Right. Got to look at the whole pattern.
Exactly. It's not just isolated numbers.
And if the initial workup points towards, say, kidney disease or poisoning,
Then you tailor your next steps. Run the ethylene glycol test if you suspect it. Image the kidneys if they're implicated. The differentials for acidosis are really the differentials for all those underlying diseases.
makes sense. Now, back to those tricky mixed disorders. How do we spot them in the heat of the moment?
It takes putting everything together: history, signs, all the blood gas values. The document gives good examples, like septic shock. Could have metabolic acidosis from poor perfusion and respiratory alkalosis from panting hard.
Okay, I see. Two things pulling pH in different directions.
Or a GBV, metabolic acidosis from lactate. Maybe respiratory alkalosis from pain and hyperventilation. Look for those inconsistencies. Is the compensation what you expect based on the bicarb or a PACO2? Are pH, PACO2, and bicarb all pointing the same way, or is one going rogue?
Those are great examples. Any other common mixed scenarios?
Sure. Think severe pneumonia, respiratory acidosis because they can't breathe well, plus they go into shock. get lactic acidosis, adding metabolic acidosis on top.
Ooh, bad combo.
Or a chronic kidney patient with metabolic acidosis who starts vomiting heavily. Now, you might layer on a metabolic alkalosis from losing stomach acid. And always remember cats. They don't usually compensate for metabolic acidosis with a strong respiratory alkalosis. So if you see respiratory alkalosis in an acidotic cat, strongly suspect a mixed issue.
Keep an eye out for those mixed signals, especially in the really sick ones. Okay, diagnosis made. We have a lead on the cause. Treatment time.
And the document is emphatic here. Treat the underlying cause.
Yeah.
That is number 1, 2, and 3.
Right, fix the root problem.
Often, that's enough. Decompress the GDV and give fluids. Give insulin fluids for DKA. The body starts to correct the acid-base balance once the primary driver is managed.
But what about directly treating the acidosis? When do we consider bicarbonate?
It's generally reserved for severe metabolic acidosis. We're talking pH below 7.1, maybe bicarbonate below 5 millimole. The idea isn't to normalize the pH completely, but to nudge it up towards 7.2, just to get the patient out of that critical danger zone where severe acidosis really harms cardiovascular function.
Okay, so only for the really severe metabolic cases. How do we calculate the dose? That always feels a bit intense.
It does. The formula is body weight in kilogram times base deficit times 0.3. You estimate the base deficit by subtracting the patient's bicarb from normal, maybe 24, BUT, big butt. The key is caution. Go slow. Give maybe half the calculated dose slowly, IV over several hours, like 3 or 4 hours. Then recheck a blood gas.
Recheck is key.
Absolutely. Frequent monitoring venous gas every 4-6 hours maybe, plus electrolytes, especially sodium. Don't overshoot.
Slow and steady. And when is bicarb a definite no-go?
Respiratory acidosis. Absolutely contraindicated. Giving bicarb when the problem is CO2 retention just adds more CO2 production, which the struggling lungs can't handle. It can make things worse.
Critical point. Always rule out a primary respiratory component first.
Always.
What about chronic situations? Any role for bicarb there?
For chronic metabolic acidosis, like in CKD, sometimes low-dose oral sodium bicarbonate can help. And for chronic respiratory acidosis, sometimes supplementing chloride, like potassium chloride, can support the kidney's compensatory efforts.
Okay. And any side effects or problems with giving bicarbonate IV?
Yeah, risks include hypernatremia because it's sodium bicarbonate and thrombophlebitis at the infusion site. And avoid mixing it with dextrose fluids. Give it as a separate infusion if possible.
Good practical tips. So careful administration, watch for problems. Once we start treatment, what are we monitoring closely?
Serial blood gases are key. Arterial preferred for the full respiratory picture, but venous is fine for tracking pH and bicarb trends. Plus, electrolytes, sodium, potassium, chloride, and albumin.
And looking at the trend is more important than any single value.
Exactly. How are things changing over time? Is the patient responding? That guides your adjustments. Arterial is essential if you need to follow PACO2 and oxygenation.
Makes sense. And the big question clients ask, prognosis, what determines the outcome?
It really boils down to the underlying disease. Is it reversible? How severe is it? How well is the patient responding? And are the acid-base numbers improving? If the primary issue gets fixed and the acidosis resolves, prognosis can be good. If not, it's obviously more guarded.
Okay, let's try and summarize. What are the absolute must-remember pearls from this deep dive for clinicians hitting the floor tomorrow?
Okay, top 3 maybe. 1, acidosis is a symptom. Find and treat the underlying cause that's paramount.
Always.
2, don't rely only on venous gas if you suspect breathing issues. Get an arterial sample for the full story.
Good advice.
3, be super cautious with bicarbonate. Only for severe metabolic acidosis. Know the risks and never give it if there's a primary respiratory component you haven't addressed.
Critical points. And we also talked about not missing those sneaky mixed disorders, even if the numbers look okay-ish at first glance.
Exactly. Look for conflicting signals. PACO2 and bicarb going opposite ways, compensation that doesn't match expectations, pH moving weirdly. Always think respiratory before bicarb.
And quickly, prevention and a technician tip.
Prevention is just aggressive treatment of the underlying causes.
Yeah.
And for techs, any change in breathing pattern or mentation in a sick patient, that warrants an immediate acid-base check. Alert the vet.
Excellent advice for the whole team. So the big picture. Acidosis is complex. You need to understand the causes, the physiology, the whole clinical picture to manage it well.
And treating the primary disease is always step 1.
So think about how understanding the anion gap better, or corrected chloride, or those flags for mixed disorders might change how you approach your next tricky case.
And here's a final thought to chew on. In those cases where the blood gas looks compensated, What subtle clinical changes, a tiny shift in breathing effort, slight dullness, might actually be screaming mixed disorder if you look close enough?
A really important question to keep asking. Thanks, everyone, for joining this deep dive. Keep learning, keep questioning, and keep doing great work out there.